Hello everyone, I'm your friend Piga. Today I will take you on an exciting journey. The journey starts with an unknown event. Events unknown to mankind. Events leading to somatic mutations of me, the PEGA gene. Oh, by the way, this isn't me. My real version is this. I'm located on X chromosome, so only one mutation is required in either males or females to abolish the expression of GPI-linked proteins. The mutation are acquired. They are either frame shift or point mutations. My home is located in the myeloid stem cells. The mutations, aka changes, are acquired. PIGA stands for phosphatidylinositol glycan biosynthesis, class A protein. PIGA encodes for glycosyl phosphatidylinositol anchored proteins. Mutations in these genes can't synthesize these proteins. The complement-regulated proteins are CD55, decay accelerating factor, and CD59, membrane inhibitor of reactive lysis, and MCP, membrane cofactor binding protein. Red blood cells lack MCP, therefore are more susceptible to complement-mediated lysis. Now, you know how do I work. Let me show what happens to my ecosystem, the human being, when I'm mutated. Mutation of PEGA gene leads to a disorder known as Paroxysmal Nocturnal Hemoglobinuria. It's not often encountered. Circa 15.4 million people are worldwide affected. Now let me take you to the clinical manifestations of Paroxysmal Nocturnal Hemoglobinuria. The magic word here is the triad. The triad is composed of hemolysis, pancytopenia, and thrombosis. The hemolysis is predominantly intravascular and leads to intrinsic intravascular acquired hemolytic anemia. The hemolysis takes place during day and night. In the night, urine gets concentrated. Early morning urine is brown in color. That's how it got its name as Paroxysmal Nocturnal Hemoglobinuria. The release of erythrocytic arginase during hemolysis reduces arginine, the precursor for de novo nitric oxide production. The low nitric oxide levels lead to endothelial dysfunction, platelet activation, and fatigue. Moreover, nitric oxide scavenging by free hemoglobin leads to smooth muscle contraction with consequent vasoconstriction, constriction of the gut, and pulmonary hypertension. These effects could explain many of the clinical symptoms that are seen in PNH patients in conjunction with a hemolytic attack. These include abdominal pain, bloating, back pain, headache, esophageal spasms, erectile dysfunction, and fatigue. PNH patients face high-risk venous thrombosis, impacting vital veins, for example, cerebral hepatic. Around 40% experience thrombotic events, a major cause of death. Recent data reveals increased arterial thrombosis risk. Quantity of PNH blood cells correlates with thrombosis likelihood alongside heightened clotting factors. Platelet and complement abnormalities are noted, but don't fully explain the hypercoagulable state. Thrombosis often follows acute hemolysis in PNH, suggesting a link between inadequate complement control or hemolysis and clot formation. Inhibiting complement activation and hemolysis significantly reduces thrombosis. Intravascular hemolysis contributes to thrombosis via nitric oxide depletion and membrane alterations in platelets and red cells. The hemolysis can lead to cholelithiasis and choledocholithiasis. PNH involves bone marrow failure and GPI-deficient blood cells. Even with normal counts, all PNH patients experience bone marrow issues, varying in severity. The causes of this bone marrow failure in PNH are not fully understood, but are likely diverse. For PNH manifestation, it's important to have clonal selection by extrinsic factor, such as autoimmune process against hematopoietic stem cells, or by intrinsic factors such as accumulation of genetic and epigenetic mutations. The clinical manifestations of bone marrow failure are anemia, pancytopenia, infections, bleeding, myelodysplastic syndrome, and bone pain. Rarely takes place transformation into acute myeloid leukemia. Aplastic anemia PNH syndrome links aplastic anemia and PNH. PNH risk in aplastic anemia relates to initial PNH clone size, 15 to 25%. Over 50% of aplastic anemia patients have small, moderate GPI deficient populations. PNH presence indicates immune-induced bone marrow issues. 10–20% of aplastic anemia patients develop hemolytic PNH later. 20% of PNH patients show abnormal cytogenetics at diagnosis. Stem cell transplants prevent secondary PNH in aplastic anemia. PNH and MDS define the course of acquired aplastic anemia as secondary clonal diseases. In PNH, kidney issues affect 2/3 of patients, with 21% facing advanced problems. These include reversible impairment due to vasospasm and damage from increased nitric oxide breakdown. Hemosiderin deposits and clots contribute to kidney damage. Most patients show impaired tubular function and declining creatinine clearance. Hemosiderin deposits in proximal convoluted tubules, as well as microvascular thrombosis, cause damage to renal parenchyma. Quite a story, isn't it? Now, you have known quite a lot about me. Now it's time to know, how will you diagnose PNH, my mutated version? Now let's discuss about the patient's medical history, clinical examination, and diagnostic workup of PNH patients. Gather family and personal medical history to differentiate acquired disorders from genetic conditions like membranopathies or enzyme deficiencies, particularly focusing on PNH-related symptoms such as fatigue, dyspnea, urine discoloration, recurrent abdominal pain crises, dysphagia, headaches, erectile dysfunction, thromboembolic events, signs of bleeding. During clinical examination, look for signs of anemia, jaundice, indications of acute or past thrombosis, signs of bleeding, constitutional abnormalities as seen in congenital aplastic anemias, splenomegaly. Lab workup includes differential blood count, reticulocyte count, and examination of red blood cell morphology are crucial to differentiate between PNH and microangiopathic hemolysis, particularly to exclude fragmented red blood cells. Essential hemolysis parameters such as LDH, total bilirubin, direct bilirubin. Supplementary are haptoglobin, hemopexin, urine test for hemoglobin presence. Optional are free serum hemoglobin and urinary hemosiderin. Additional tests include direct antiglobulin test, DATE, blood typing, highly sensitive flow cytometry from peripheral blood, GPI-anchored proteins, bone marrow. Cytology, cytogenetics, molecular genetics, and histology are being simultaneously investigated due to the presence of such a severe cytopenia that raises suspicion of a PNH in the context of another hematological disorder, particularly aplastic anemia or MDS. Upper abdominal ultrasound with color. Doppler focusing on liver and spleen size. Doppler signs of acute or resolved hepatic, portal, splenic, or mesenteric vein thrombosis. If suspected acute thrombotic event, possible additional color Doppler and angiography of other areas, e.g. cerebral veins, flow cytometry and its indications. Indications for flow cytometric assessment of GPI-anchored protein expression. Acquired Coombs negative hemolytic anemia, excluding microangiopathic hemolytic anemia, intravascular hemolysis with low haptoglobin, hemoglobinuria, increased free plasma hemoglobin. Thrombosis, at a typical location such as sinus venous, Budd-Chiari, mesenteric/portal/splenic vein, etc. Thrombosis with signs of hemolytic anemia, elevated LDH. Thrombosis with unclear cytopenia. Thrombosis without risk factors, including arterial. Unexplained iron deficiency anemia with hemolytic signs. Diagnosis or suspicion of aplastic anemia. Diagnosis or suspicion of low-risk MDS, recurring abdominal pain or dysphagia with signs of hemolysis. Flow cytometry. Various cell lines, for example granulocytes, reticulocytes, with at least 2 markers examined per cell line. Reports should include quantitative data on cell lines, detailing cells lacking GPI-anchored proteins or with reduced expression. As far as sensitivity goes, routine detection of GPI-deficient populations at a relative proportion of 1%, but a threshold for 0.01% for aplastic anemia patients. Peripheral blood, preferably ET anticoagulated, is required. Analysis is ideally done within 48 hours of collection. Refrigeration is recommended for transport over 24 hours. Oh boy, that looks simple. There are a lot of details in there. Now let's come to the therapy of PNH. Let's discuss about therapy and treatment of PNH. Allogeneic stem cell transplantation is the potentially curative therapy for paroxysmal nocturnal hemoglobinuria, PNH, particularly when it occurs alongside severe aplastic anemia. Complications such as secondary bone marrow failure, progression to myelodysplastic syndrome, MDS, or acute leukemia, and recurrent thromboembolic events despite other therapies may prompt the need for allogeneic stem cell transplantation. The therapy involves using antibodies, eculizumab and ravulizumab, to inhibit the terminal complement system. Ravulizumab, a modified version, has a longer clinical effectiveness due to its pH-dependent dissociation in endosome and pH-dependent binding to the neonatal Fc receptor, allowing for extracellular recycling, extending its half-life from 11.3 to 49.7 days compared to eculizumab. Eculizumab therapy involves a weekly dose of 600 mg for 4 weeks, followed by 900 mg every 2 weeks. Ravulizumab therapy includes an initial weight-dependent dose, as shown in the picture, and maintenance doses every 8 weeks. Ravulizumab therapy uses weight-based dosing. An initial dose of 2,700 mg, 2,400 mg for more than 40 and less than 60 kg, 3,000 mg for more than 100 kg. Then, a 3,300 mg maintenance dose, 3,000 mg for more than 40 and less than 60 kg, 3,600 mg for more than 100 kg. Repeat every 8 weeks. Mandatory meningococcal vaccination is required for complement inhibitor treatment. Contrary to initial recommendations, it is advisable not to administer this vaccination before the first eculizumab or ravulizumab infusion to avoid potential complications such as accentuation of hemolysis, leading to a hemolytic crisis and serious thromboses. A primary antibiotic prophylaxis can be implemented until the vaccination is administered. The use of C5 inhibitors in complement therapy often leads to persistent anemia in over 60% of patients, with about a third requiring ongoing transfusions. Patients with significant bone marrow insufficiency may experience limited improvement in anemia through complement blockade. Extravascular hemolysis plays a key role in ongoing anemia under C5 blockade. Pegcetacoplan, an advanced C3 and C3b inhibitor, demonstrated superior efficacy over eculizumab in a phase 3 study for treating ongoing anemia, achieving transfusion independence, and enhancing the quality of life in paroxysmal nocturnal hemoglobinuria, PNH. Patients with symptomatic anemia due to extravascular hemolysis. Before starting pegcetacoplan therapy, it is essential to check patients' vaccination status. Mandatory vaccinations against capsule-forming bacteria, meningococci, both tetravalent vaccine covering strains A, C, W, and Y, and a vaccine for strain B, pneumococci, PCV13 followed by PPSV23, spaced 6-12 weeks apart, and Haemophilus influenzae type B, Hib, are required before switching therapies. This recommendation is in line with AJIHO guidelines. If there is an indication to switch from a C5 inhibitor to pegcetacoplan, therapy initiation involves a 4-week run-in phase where C5 inhibitors are co-administered with pegcetacoplan. The dosing of pegcetacoplan is 1080 mg administered subcutaneously. Under proximal complement inhibition, two significant effects occur. Firstly, there is a notable increase in GPI-deficient erythrocytes, exceeding 90%, highlighting the therapy's effectiveness in extending the lifespan of these cells. Secondly, incomplete inhibition in the proximal complement cascade, termed breakthrough, permits C5 convertase activity, amplifying the formation of the membrane attack complex. This partial blockade of C3 significantly enhances intravascular hemolysis activity. Elevated LDH above twice the upper limit and fall in hemoglobin of more than 2 grams per deciliter is suggestive of breakthrough hemolysis. Clinical breakthrough is defined by presence of one of the two clinical criteria and laboratory evidence of hemolysis. Pegcetacoplan. Dose adjustment from twice to thrice a week is required. In severe cases, switch to a terminal complement inhibitor may be considered for long-term treatment. Patient education is also a very important aspect. Last but not the least, there is tentative classification of hematological response to anti-complement agents in PNH, which can be a great tool for the clinicians. The key points in the supportive therapy of hemolytic paroxysmal nocturnal hemoglobinuria, PNH, are as follows. These include substituting red blood cell concentrates, administering folic acid and vitamin B12, managing iron levels cautiously, and avoiding uncontrolled iron administration during complement blocking therapy. Early and consistent antibiotic treatment for bacterial infections is crucial to prevent complications. Adequate hydration is recommended during crisis-induced hemolysis. Lifelong anticoagulation is recommended after a thrombotic event. Complement blocking therapy is advised due to the risk of recurrence. Mobility-restricted patients should consider complement blocking therapy. Primary prophylactic anticoagulation is considered for those not on complement blocking therapy. Both coumarins and heparins are suitable. Limited data suggests direct oral anticoagulants may be effective, especially with complement inhibitors. There is elevated maternal and fetal risks, including atypical thromboses. There is no apparent teratogenic effects under eculizumab therapy. There is a lack of data for ravulizumab and pegcetacoplan. It is crucial not to interrupt eculizumab therapy upon pregnancy diagnosis, and its use during pregnancy planning requires careful consideration, potentially involving dose adjustments. However, initiating therapy with ravulizumab and pegcetacoplan during pregnancy or when planning conception is not advisable until more information is available. In summary, therapy mid-terminal complement, C5 inhibition, and proximal complement, C3 inhibition. Assessing the therapy response and consideration of vaccination strategies. There is still a lot of space and questions in the following situations. Pregnancy, previously primarily eculizumab therapy. Anticoagulation therapy, breakthrough hemolysis therapy. Regular assessment of parameters, which include LDH, reticulocyte count, C3 loading. Consideration of important factors such as compliance, infections, costs, study points. Bye-bye and happy learning.